WCLN 1170 Radio and Cable Channel 16 are pleased to present We Should Know, hosted by J.W. Simmons, an upbeat, informative look at people, places, and issues facing our community. This education-based analysis of issues will remain positive and informative as we consider closely what we should know.
Ladies and gentlemen, welcome back. I want to thank you for being with us today. We Should Know is on the air. We're coming to you on WCLN Radio. We're simulcast with Star Communications on Channel 16 visually. We've had a couple of shows the past 2 weeks. We talked a little bit about history with folks at the History Museum, and we've had quite a bit of commentary on the shows we've had. We appreciate those emails and continue to let us know what you think to weshouldknow@edu@gmail.com. We've got with us today one of, I guess, the most important guys around town, would say, is a orthopedic surgeon, Dr. Huff. I want to thank you for taking your time out of what is a busy schedule, because you're now back to a single surgery practice, and unfortunately Dr. Cook, for us unfortunately, decided to move on. So I want to talk about that for a minute, but just give folks a little bit background with you. You grew up and attended East Carolina University, got your degree in medicine there, graduated with highest honors. You completed internship and 5 years of orthopedic surgery in residency at Orlando Regional Medical Center in Orlando, Florida. Completed an additional fellowship of a year training in orthoscopy and joint replacement at Florida Knee Center in Clearwater, Florida. Opened your practice in Clinton, North Carolina, 1998, married with 3 children. That kind of gives everybody a little bit of summation, but I would dare say that probably people know more about Dr. Alex Huff than they do this show or anything else that's going on. So you're a busy guy. How's the practice going now, and are you able to sustain, because I know your office stays full?
Well, I'll tell you, things are going well at the office. We've had a tough 6 weeks or so with the loss of Dr. Clark, and I hated that. He was a great guy, and I think he was very happy here, and he was really finding a place in the community and enjoyed it. But unfortunately, he's got family ties up in the Pittsburgh area that just pulled too hard, especially once he had his first child. Mm-hmm. And I don't think that his vote counted as much as some of the other family members, and so he's back in Pennsylvania now. So that's been a loss. I do have a new office manager that I was able to hire from Raleigh Pediatrics, and she happened to relocate to Sampson County, and that's been a big plus. She brings a lot of experience to the office, and so we're in a little bit of a period of change right now, but I think those changes are going to be really good, and so things are looking up. But I can't thank people enough for the confidence they have in me and my practice. I never knew that I would be here, 18 years, and it looks like I'll finish my career here, which is a wonderful thing. I came here thinking I'd stay a couple of years and move on, but the people here have embraced me and have accepted us, and my family, we've raised 3 children here, and I really couldn't be happier and couldn't say enough good things about this community.
Well, we appreciate you being here, and I know we had Dr. Jason Clark on, and we talked with him some time back. One of the interesting things was in that conversation, the idea of a lot of doctors with the caliber that you have and the critique of your credentials. It's hard to get to a rural area. Kind of help folks understand a little bit, because especially as we're going through this huge change in medicine now, it becomes even more of a complex issue.
Right. Every doctor, specialist, every specialist surgeon, whether you're a ear, nose, and throat surgeon, an orthopedic surgeon, or a plastic surgeon, or anything, any type of specialty surgeon is really dependent a lot on the local primary care doctors in the community, and so I think a lot of the doctors are hesitant to come to a small community because they're afraid they won't have the safety net of the constant referrals from a large internal medicine or family practice group, that or have the safety net of a large hospital system. For instance, if you're employed by a 600-bed hospital that already employs hundreds of doctors, or if you're a member in a large group, for instance, like Wilmington Health Associates in Wilmington, you're going to receive all of the orthopedic referrals from those primary care doctors and the medical subspecialists, and so you don't have to worry about having a full schedule. I've somehow managed to keep a full schedule here, through the help of all of my family medicine colleagues in town and internists, and then also through word of mouth, and so things have worked out for me. But I think a lot of doctors are hesitant to enter into an environment where they don't have the guaranteed referral patterns.
Well, and I think one of the things too is that you created a reputation of quality work, some of the latest technology, and the thing that's always interests me, and we've talked about this, and I'm going to touch on it again, is this idea that oftentimes folks say, well, I'm not sure I want to go to somebody local because they might not be able to do something, but your philosophy is kind of unique. If it's something that you're not familiar with or you're not really locked in and can do, the first thing you say is, look, I'm going to refer you somewhere else.
Absolutely. I would say every day I refer a couple of patients to colleagues and friends, whether it's if it's anything that's either rare or complicated or that I don't do or that I don't think that we should be doing, particularly at a smaller community hospital. I can pick up the phone and call any number of other orthopedic surgeons. Fortunately, I've made great relationships with orthopedic surgeons in Raleigh and Wilmington, both, and then also at UNC at Duke and in Fayetteville, and of course my friends in Goldsboro. But so I've made good relationship with these guys. I can pick up the phone and call, for instance, a hand specialist in Raleigh or a revision specialist at Duke or something, and that's been a good thing. I like to say that if I don't do it every week or every month, I don't do it at all, and I'm going to find someone else who does. There's people out there that specialize in all types of orthopedic surgery. I cannot be a master of everything. I do what the community has. I take care of the majority of what happens in the community. But when something does happen that's rare or different, I'm going to get you to someone else who's got more experience than I do.
I want to kind of get into some of the more innovative things that's been happening with various kind of everything from knee replacements running around since we last talked, because medicine goes through this technological change and we see new stuff coming out. At the same time, we also see stuff that's been around for a decade being labeled with a different label, and It's the same thing. So let's kind of get down. I know some of the things, these non-operative treatments for knee replacement and injections and those kinds of things. Let's talk about that a bit, and what do you see actually working? What do you see as being labeled as something that's really innovative but has been there for years?
Right. That's a very interesting topic. And, Solomon, I think, said there's nothing new under the sun, and that's to a large extent true. Things are repackaged, reprogrammed, and retried and resold. But anybody that reads the newspaper or listens to the radio lately has heard commercials about different specialty knee pain clinics to treat knee pain, to treat osteoarthritis, non-surgical treatment. And for instance, one that I see in a full-page ad in the News Observer every day, which is a very expensive ad, I can tell you.
Yeah.
So somebody's got some money behind it, but offers a 5-step treatment program, and all of those steps are actually offered here at our office and have been offered
since
for
1998
years.
probably.
Right. For instance, they'll talk about reducing inflammation. Well, that's cortisone injections, and they've been around for 50 years and have proven to be safe and effective. But they do have limited use, and you have to limit the numbers of injections and things. But they do work well, and I can testify to that because I've injected my own shoulder and my own knee from athletic injuries over the years, and they work great. And patients testify to that too. They'll talk about coating and lubricating the joint, and that's with hyaluronate injections. And I've had patients come in and ask me, have I heard of these or do I do these? And actually, I was involved in an FDA study in the late 1990s in Florida, but I've been using the very first branded FDA-approved source of hyaluronate acid was called Hyalgan. I've been using that since 1998. Over the years, I've used other brands, Orthovisc, Synvisc, Supartz, and the newest one now is called Gel One. It's a single shot. But basically, hyaluronate is an amino acid protein gel that is very similar to healthy joint fluid. It can be injected into the knee and will thicken the fluid that's already in the knee and cushion against the bone-on-bone arthritis. And they work very well too. There was trouble in the early years getting them approved by insurance companies because they're expensive. But now just about every insurance company will authorize them for use in the knee, and so we use them on a daily basis.
And that's called
hyaluronate is the technical term. There's different brand names on the market, but basically it's a lot of people call it the rooster comb shot because the very first original shots, the Hyalgan shots, were derived from rooster comb fluid. So and it's used in other forms of medicine too. The plastic surgeons use it for crow's feet around the eyes. It's called Restylane. And then the ophthalmologists use it inside the eye to replace the fluid that is normally in the eyeball. So it's used in other forms of medicine. It's very safe. There's really no side effects. and it works well. The problem is getting it authorized through insurance, but we're able to do that now pretty easily.
Is that kind of injection one that you find is 50% or more people have success with it? Is 50% or less people?
Yeah, I tell people 70% of the people that get it will get at least a 70% improvement in pain, and it'll last at least 7 months. And so I kind of use that 7-7-7 rule, which is pretty good. So that, I think it lasts longer than cortisone injections. It may take a little longer to start kicking in. A cortisone shot will work within a couple of days and last several weeks. A hyaluronate injection may take a couple of weeks to work, but it'll last several months. Then the latest ones, the newest ones, are these plasma-rich platelet injections, or PRP injections, and that's where scientists have noted that platelets are really the first cell to arrive at an injured area. If you cut yourself, the platelets come and seal it off. And so platelets have with them chemical factors that promote healing. And so what you can do is draw blood from a patient, put it in a centrifuge, spin that blood at a high speed for a few minutes. The platelets will rise to the top. You can then draw those platelets off from that test tube and inject them into a patient's knee. And studies are coming out now that are showing that that's very effective. There's some good data showing that much better than placebo at treating osteoarthritis. And there may be something to the fact that it helps to, basically it's jump-starting the body's natural healing process. It's been used in professional athletes, people, Kobe Bryant, Peyton Manning, these guys, they were paying for it out of their pocket. There's a big push to try to get it approved by insurance companies. Right now, that's not been successful. But I think with some of the new data that's coming out that shows it to be effective, I think insurance companies will start covering it. But right now, it's a few $100s.
Well, one of the things I want to do is when we come back is pick up where we are with this and talk about at what point do you look at a joint or a replacement and say we've got to go in or we need to go in and replace that either with artificial or some other device that the lubricant kind of process doesn't work anymore. So we'll be back in a moment to do that. Ladies and gentlemen, stay with us. Call a friend. We're talking with Dr. Alex Huff, orthopedic surgeon right here in Clinton, North Carolina.
You're out for an evening on the town. Finally a chance to relax and forget that you left your front door completely unlocked. Fortunately, you just installed a security system from Star Communications. With just your cell phone, you can check on your house, lock it down, light it up, and get back to relaxing.
You forgot to put Buster in his crate.
Unfortunately, we can't help with that. Security and automation from Star Communications. Call today to find out more.
Ladies and gentlemen, welcome back. We're talking with Dr. Alex Huff today. And Huff Orthopedic Surgery and Sports Medicine. 2011, Dr. Huff, you were one of about 1,500 orthopedic surgeons in the United States who was certified also as an orthopedic sports medicine surgeon. I'm sure those numbers have changed a bit. You've served as the medical director of the physical therapy at the Center for Health and Wellness in Clinton. You also do a lot of work for high schools and sports athletics and understand the concept of impact sports. And as we go on, I'm trying to let folks understand we're going to get into some of these discussions in the last part of the show, so I want parents, grandparents, and others to start listening because that's their children desire to play in sports, so we're going to talk about that. As we look at where you've been since 1998 and here, you have become the place to go for anything that hurts or aches or if it don't feel right when somebody gets up in the morning. One of the things we were talking about when we went off air was this lubrication process and the various kinds of lubricants. At what point in time is there a process you look at somebody and say, look, we've tried 3 or 4 different injections and now we need to look at replacement? And that usually kind of, I'm sure, brings pause to a lot of people.
It does. It's just human nature to try to think that we're all invincible and that we can last forever. And people are living a lot, longer now. I mean, people are living into their 90s routinely. Orthopedic surgery has probably lagged behind some of the cardiac care and some of the pulmonary care. So with all the new statin drugs to lower your cholesterol and new blood thinners, people, instead of dying at 72, they're living to be 85. Orthopedic surgery has lagged behind a little bit, I believe, mainly because we got such a late start. We didn't start really doing modern joint replacements until the 70s. And so, and they weren't lasting that long. But I'll tell you now, joint replacements have got at least an 80% chance of lasting more than 30 years, which is a good thing. That's improvement. But in terms of when someone is no longer a candidate for these types of injections, I tell people all the time, if you have a flat tire, what's the first thing you do? You pull over on the side of the road, because if you keep riding on that flat tire, you're going to ruin the rim, so to speak. And a lot of people, unfortunately, are getting to my office late. They've already ruined the rim. They've been hurting for years. They've now developed deformity, stiffness, weakness, and chronic pain, to the point that it's really impossible, medically impossible, to restore or regenerate that tissue. The time to come in for these types of injections is in midlife and early late life, or when you first develop symptoms. Someone like yourself that runs, if you have several weeks of knee pain that's not going away, that's something that needs to be evaluated. God made us in a way to heal most problems, and a lot of people will get better on their own, which is great. But still, if we can do something to stop the degeneration of the cartilage, that's a good thing. And I think that some of these injections are promising for that. We talked about the platelet injections. The other one is called stem cell injections. And stem cell injections, there are some stem cells in the platelets, and that's a good thing. But on the horizon is using human adipose tissue to withdraw stem cells from some of our fat cells, number one. And number two, using commercially available stem cells that come from amniotic fluid. Nowadays, if someone delivers a baby, they take a sample of cord blood, they save it. Well, some of that cord blood is used to derive stem cells that are then commercially prepared and sold to hospitals and clinics for medical use. And there's some promise that some of that's helpful. I personally think that using your own tissue is better than using tissue that's from another person. But
and anyway. I think that's kind of been proven with cardiothoracic surgery as well.
Correct.
Using your own tissue. So as we look at this and trying to put it where folks can understand, when they come in to see you, their expectation may be one thing, but the science may reveal something totally, completely different, and folks should be somewhat prepared for an education ride, should I say.
Right, I mean, there's a spectrum of disease, from minimal disease to severe bone-on-bone, where there is no options other than joint replacement. Trust me, I enjoy the work I do in my office, and about half, most people probably don't know this, but about half of my business comes from the clinical and office side of things, and about half comes from the surgical side of things. I did 2 surgeries this morning, but I'm going to go this afternoon and hopefully see 35 patients in the office. So, and of those 35 patients, probably only 1 or 2 or 3 will end up going to the surgery schedule. There'll be non-operative treatments available for the majority of them. I enjoy both sides of it. I don't want to be a machine that just does knee replacements. I've had job offers for that. I enjoy taking care of old, young, male, female, throughout the whole spectrum of disease. So, but people will get an education about what they're candidate for, and if there's a way that we can do it without surgery, we're certainly going to try that.
One of the things I've heard you mention in the past too, you've talked about replacement and joint replacement itself, and there's a lot of new technology that's come out, and there's a lot of information that talks about these knee replacements or joint replacements that are made specifically to fit your particular joint and those kinds of things. And one of the things I've heard you mention is that oftentimes you look at things that have been tried and proven. At what point in time do you feel comfortable moving forward with maybe something new that's come out and saying, okay, I'm willing to try that? Now, do you give it a year, 2 years? Or?
I'll tell you, once it gets out of the lab and into the university level teaching centers, that still doesn't mean it's good. Just because it's done at a university level, it's usually being done through a grant of some sort, a government grant, NIH grant, something like that. And it may be something that's erroneous and not good, and that grant, and then what we learn from that is don't do this, okay? Once it gets to the community hospital level, the high volume community hospitals, that's when I start getting on board too. And I attend meetings and have discussions with colleagues all the time about what's good. And there's some things we've incorporated just since I've talked to you last in our practice. The length of stay for knee replacement now is dropping. I've had some patients spend 1 night in the hospital. I've had many patients only spend 2 nights in the hospital. There's a new medicine that we're injecting at the time of surgery around the knee that is a long-lasting pain medication that lasts for 3 or 4 days. If you can imagine going to the dentist and getting your tooth numbed, it lasts for 3 or 4 hours. It's a medicine like that, but because of the composition of it, it will last 3 or 4 days, and that's allowing people to get up moving faster and get out of the hospital sooner. There's better techniques for blood conservation. The risk of getting a blood transfusion, or the need of getting a blood transfusion, really is approaching 1%. Okay, so most people don't need. It used to be routine that you would donate blood before surgery, or get one of your family members to donate because there was a high risk of getting a blood transfusion. That's pretty much gone away. Blood thinning medicines are safer now. So there's a lot of things that, and you were talking about custom implants. We can now use CT and MRI scan to make custom cutting blocks for your particular surgery, custom implants, so that they're specifically designed to fit the bone structure that you have, which is a great thing too. And we offer that here.
When you do a knee replacement and you communicate with the patient that's getting that place, and I'm using knee replacement because you do hips and everything else too, but the reality is, what do you set the level of expectation for that patient? I mean, there's obviously going to be some pain associated with it. There's going to be a time of adjustment and endurance.
Right.
What is typically you're seeing as the average for a person to walk out or to get up and start moving around and have full mobility?
Well, basically, this is what I'll tell people. And the operation takes me about an hour or so. They'll come in that morning for surgery, have the operation. Before noon, they're back in their hospital room. Hopefully they're getting out of bed then. Certainly by the next morning, they're taking steps around the room and out in the hallway. And by the second day, walking in the hallway with the physical therapist, and at that point, if their pain is well controlled, they're able to go home. We then set them up for either in-home physical therapy or outpatient physical therapy, depending on where they live and whether they've got transportation to and from the wellness center, for instance, or if they live out in Garland, for instance, we may have in-home physical therapy. After about 3 weeks, they're off their walkers or crutches, they're driving their car, and they're able to get out in the community. After 6 weeks, most people are doing 95% of what they want to do. So the recovery time has dramatically shortened, barring any unforeseen complications. And I'll tell you, Blue Cross sent us a commendation this past fall talking about our overall cost of care being the best in their service area. And that included readmission rates, complication rates, infections, et cetera. So whatever we're doing a great job because our numbers are a fraction of what the national numbers are in terms of infection, readmission, blood clots, and those other devastating complications. We just don't see them in our practice, which is a great thing.
Well, one of the things you mentioned that I want to follow up on too is that a lot of times at the larger university level hospitals and so forth, the volume of patients alone creates a lot of concern about transference of disease and those kinds of things. The smaller hospitals, if you look at it just strictly from a numbers point of view, it would seem to have a much less probability of those kinds of transferences.
Right. I mean, where do the sick people go? Is the question. They go to Duke and UNC.
Yeah.
That's where the sickest people are, and so these rare, difficult to treat infections get shipped to those places. They're not in Sampson Regional Medical Center. So I think that's one reason why. There's several reasons why, but I think one of them is the fact that I can kind of control the environment we have at Sampson Regional since I'm the only surgeon there. And then the fact that people just aren't as sick, you know. They don't bring those types of bacterial infections into our hospital. They're going to the tertiary care facilities. And so why go to a place like that for a knee replacement? Is a big question.
The concept of replacements with knees, hips, those kinds of things, you find that same process with a hip replacement over a period of time is pretty much equal as far as recovery?
Yeah, hip replacements are not as painful. I'll tell you, knees do hurt because you've got to get the joint moving. A hip doesn't need to have the range of motion that a knee does, and people don't like it when they can't straighten it or when they can't bend it. But with their hip, they all move pretty well. So hips don't seem to hurt as much, but the overall length of stay, et cetera, is about the same.
Well, we're going to take a break. We'll be back in just a moment. I want to continue this discussion about some of the replacements and some of the specialty stuff you do. Ladies and gentlemen, thank you for being with us. We'll be back in one moment with Dr. Alex Huff. We're talking about things that will help remove pain from you. We'll be back in one moment.
Whether it's video, voice, internet, or cellular, Star Communications connects you to the things you love. It's what we do and have done for over 50 years. Star Communications, your local technology company.
Ladies and gentlemen, welcome back. I want to thank you for being with us today. I want to thank all those folks at the radio station mention us each and every week. The morning show with Grandpa, Nolan C., the L-Man, and of course Wayne Weeks with the Gospel Hour each and every day, and Nicole does the Country Store. Robert Stroud with the Boogie Shoes Radio Network on Saturday afternoon. Tommy the Fly in the afternoon. We thank him and all those folks for mentioning this show and also the guests we're having. Today we've got Dr. Alex Huff, the #1 surgeon in this part of the country as far as we're concerned in Clinton, North Carolina. You probably see more people than folks can imagine. We were talking a bit on break about a new procedure called the reverse shoulder replacement, and I found it kind of fascinating when I first saw that. And I want folks to understand, first of all, what happens to the shoulder that oftentimes creates problems not only for older folks, but for athletes and folks that are maybe in sports, or maybe they're just folks working on a farm somewhere and come in with extreme pain. Give us kind of the broad picture and then tell us the reverse thing. That is really interesting.
Well, with the shoulder, usually the spectrum of disease starts with what's called impingement with bursitis, and that's something that can be treated with physical therapy, injections, medications, etc. And then if the impingement gets worse and those bone spurs start to rub into the rotator cuff, you may need, and if the conservative treatment's not working, you would need an operation, an arthroscopy of the shoulder, quick outpatient surgery where you put the light and the camera in the shoulder, remove the bone spurs, and then repair the rotator cuff if necessary. As the disease process goes on, if it's left untreated, the rotator cuff can completely tear and become atrophic and non-functional. When that happens, the ball rides high in the shoulder joint instead of down in the socket where it's supposed to, and it basically ruins the shoulder socket and the ball. And so in the past, shoulder replacements to replace the ball and socket have been done, but they require an intact and fairly healthy rotator cuff. So they were good for people that maybe broke their shoulder that still had a rotator cuff, or for younger people that had arthritis but still had an intact rotator cuff. The rotator cuff is very important at maintaining the balance in the ball and socket joint so that the arm can be lifted with minimum effort. When there is no rotator cuff, there's been no surgical solution for these patients. I mean, there was really nothing you could do. You could try a shoulder replacement, but really the function was not very good. People could never get their arm up over chest level. And then recently, I'd say in the last 6 years or so, a reverse shoulder replacement has been developed. And this is one of those things I was telling you, I watched as it came through. It trickled down from some of the places in Europe and some of the specialty centers and university centers in the United States down to the community level, and we started getting some 3 and 4 and 5 year follow-up on these patients with reverse shoulders, and found that even in these patients that had no rotator cuff, they still had functional mobility and the ability to do things overhead, which is a great thing. Yeah. And so I've incorporated that into my practice through different training facilities and continuing education, and now I'm doing that routinely on patients here in Sampson County. And the results have been very good. I'm amazed at how much pain relief the patients get and how much function they get in terms of their ability to lift their arm higher or further away from their body than they were able to do so before surgery.
When we say reverse, are we, and just visually to give folks a picture, is this a complete reversal of the different sides of the body for the rotator cuff?
It really is. Basically the way our body is built, and if you look at a skeleton or a cartoon picture of a skeleton, you'll see this. The upper arm bone has a ball at the top, and the shoulder blade has a socket, and the ball fits into the socket. Well, if you reverse that and put the ball on the scapular side or on the shoulder socket side, and the socket on the upper arm, it moves the center of rotation of the arm so that then the deltoid can lift the arm. And so it allows you to use your deltoid muscle, which most people have a functional deltoid. That's the muscle on that you feel when you touch your upper arm. That deltoid muscle can lift your arm away from your body, even in folks that don't have a rotator cuff, if you reverse the ball and socket. And so that was a great idea. I can't even remember who exactly came up with that, but it's worked well. And now it's routinely, I'd say probably about 25% of the patients that have shoulder replacements are better served with a reverse shoulder replacement.
That's kind of a physics engineering thing. Whoever came up with that had to have some kind of background.
Absolutely. There's in the production of these implants, it's amazing, but there are PhDs in kinesiology, PhDs in metallurgy, and PhDs in physics, along with medical doctors and surgeons that work in laboratories, thankfully, to come up with these types of things. But it's really a phenomenal breakthrough because, like I said previously, there was really no good surgical option for patients that did not have a rotator cuff.
So when we look at where we are now with a lot of the replacements you're doing, and you mentioned metal and some of the other kinds of titaniums and those kinds of things that's being used, are we at the point now that we can, as you mentioned, say 10 years, 15 years, or 20 years, be pretty confident that if something goes in that you're going to be pretty well taken care of for at least that period of time? So, for example, if a person's in their 60s and it's going to last 25, 30 years, pretty much that's going to be, they're not going to need to go back, I guess.
Unless you meet Methuselah.
Yeah, there you go.
They're going to be 969 or something. Yeah. You're going to be able to take care of them well until their 90s. What's interesting, there was a small hiccup just in the last couple of years, and you've seen all these recalls in the papers and lawyer ads and things like that of metal on metal hip replacements. In the lab, it was something that worked great. You could cycle a metal on metal hip replacement millions of times and generate very little wear. It had very little friction. But you put it in the human body, and even if it does generate small particulate debris from wear, our bodies don't have a way to really metabolize or get rid of those metal ions, and that's causing a problem. And so that's something that made it to the university level and to the community level, but turned out to be a bad thing.
Because the longer term started proving what the problem
was. The 10-year follow-up started looking bad. And so you have to be very careful. An old doctor told me, he said, never be the first to do anything and never be the last to do anything.
Well, and that kind of moves us to part of the discussion I want to talk about today too, is this whole issue of sports medicine and what you're doing with that, because we're kind of fortunate, I guess, in a number of ways. Number one, to have you here as an orthopedic surgeon, but the sports medicine side of it is tremendous, especially since we talked last, the movie Will Smith starred in on concussion has really brought a lot of attention to what we do with sports, how we play sports, how you coach sports. And I know you go out a lot of times and you do assessments and you work with coaches and you understand what's going on, and probably one of the most highly recognized areas of concern is in the concussion area is football. So where are we with that? And for parents that are listening today, what would you say to them as it relates, should I put my child out there? Are the coaches that we have in our schools, do they understand what you understand, this trauma that causes this jelly in their head? It's called a brain.
Well, I'll tell you, that's an interesting topic, and I could go on and on about it. But I mean, basically back at around 2008 or 9, I saw the need and the direction that orthopedic surgery was going in terms of subspecialization, and I went through a 3-year process of getting certified as an orthopedic sports medicine specialist. And now there still remains less than about 3,000 members in the United States that are board certified in both. Now, the concussions started getting so much attention around that period of time. And I was fortunate, if you've had a child that plays sports, they have brought home paperwork for you to sign. One of those papers they sign is, at the top, is called the Feller-Waller Law Act, the Feller-Waller Act, named after 2 unfortunate high school kids who both died of concussions, one in Winston-Salem and one in Greenville. And so the family of Mr. Feller happened to have some influence. He worked for Lowe's Corporation. Well, Lowe's is a big NASCAR sponsor, and so through the NASCAR sponsorship, Mr. Feller, who had lost a 15-year-old son at R.J. Reynolds High School in Winston-Salem, met Richard Childress, who a lot of people in this area know of. He was Dale Earnhardt's racing team. Richard Childress Racing. And Richard Childress, benevolent man, just a wonderful human being, took it upon himself to help provide money and contacts to get this law passed for Mr. Feller. I was at an event one time and met Mr. Feller and talked face to face with the man who had lost his 15-year-old son playing football.
That had to be traumatic.
So I took a special interest in this, and now we offer impact testing in our office. Impact testing, if you don't know what that is basically a computer-based test that can help determine residual effects from a concussion and to help to determine, along with other things, whether it's safe for the child to return to play. That form that I just told you has to be signed and completed by someone that's got training, a doctor training with training in concussions, an athletic trainer. It can't just, no longer can a coach just say, get back in there, Johnny. Now, the good news is that coaches have been trained, trainers have been trained, more medical doctors have been trained, parents are more aware of it. So I think that football is as safe as it's ever been. The equipment is improving, the tackling rules are changing. The game has changed so much, I don't even know if I could help coach because the methods of blocking and tackling have changed so much since when I was in high school, and it's become safer. So I think it was important to stay on top of those things in sports medicine so that I could help identify, treat, and help prevent, hopefully, some injuries in our community.
And those impacts and the way coaches train those the kids now, as far as not doing headbutts and some of these other kinds of things. When we come back from break, I want to kind of talk a little bit about the equipment side and kind of get your vision, which we were talking on break. There is the engineering piece that maybe we need to look at something completely different with equipment that might not be as I guess visually acute, but in reality, if that's what it takes and there's a need to continue the sport, we need to do that. We're going to take a break. We'll be right back. Ladies and gentlemen, thank you for being with us. We're going to take another quick break. We'll be back with Dr. Alex Huff, Huff Orthopedics in Clinton, North Carolina, and sports medicine. Been here since 1998. We'll be back in one moment.
Give me a home where no burglar can roam, where my kids and their pets safely play. With security by Star, I can check in from afar, hit the lights, lock the door, night or day.
Really? Yeah, I can see my cameras, switch the lights, lock the doors, set the alarm, all from my phone.
Their prices are right, my home's locked up tight, Star Security makes me feel great.
Folks, thank you for being with us today, and we're back from our break. This is our last segment. We're talking with Dr. Alex Huff with Huff Orthopedics and Sports Medicine right here on Beeman Street in Clinton, right across from the Sampson Regional Medical Center. Dr. Huff, thank you for taking time to come in and talk to us today. It is the beginning of school, and we went off air and we're talking about sports. A lot of kids out there playing now. Of course, the football practice has already kicked in. Friday Night Lights is back out there. A lot of parents are excited about it. This is a #1 issue for not only children, but for parents. I get as much commentary from parents after I have you on because they're thinking about the safety side, but at the same time, they get so much enjoyment with tailgating and various other things. So let's talk about that equipment piece and what are we looking at? Are you seeing any major changes in engineering? You know, we were talking off air in the 50s and 60s. We saw folks out there with leather straps on their head and they were running around, and it was, so I don't know what happened to some of those folks. They're probably still walking around out there.
Well, I've got several points and thoughts that come to mind, but number one, the game has changed, and so the equipment has had to change. I've had the pleasure of meeting some older retired football stars from the NFL, and I'm amazed at how small they were. I'm meeting guys like Jim Richard, who was All-Pro at NC State, played with played in the NFL for 11 or 12 years, a starting guard, and he weighs 200 pounds. Okay, these guys now are 6'5", 6'6", 6'8", and 300 and something pounds. So the game has changed. The running backs and the tailbacks. You got running backs now that bench press over 400 pounds, 450 pounds, and that's just amazing to me. So the inertia behind these impacts and collisions is greater now than it used to be.
It's called getting hit by a car.
It is, and so the equipment's had to change. But one philosophy, and we spoke about it, one time in the past, but I really believe that there's got to be a fundamental change in the football helmet. There's research being done on this. with contact electrodes and stuff and measuring impacts. But if you look at something like boxing, which to me would be the most traumatic for your head that you can think about, these guys
repeated blows.
Yeah, older boxers end up retiring because they're punch drunk. They're punch drunk because they've been hit in the head so many times. Increased risk of depression, Alzheimer's, all these things that are linked to head injuries from boxing. Well, what have boxers done? They've put the cushions on the outside of their helmets. They've got, if you look at sparring matches and stuff now, they've got thick cushions on the outside. What I think needs to be done with a football helmet is putting the thick cushions on the outside.
Reverse engineering.
Reversing it, yes, or adding to it in some way. The problem is that it's not going to have the impressive logo on the side. It's not going to be the sleek silhouette. It's going to change fundamentally the way the football game looks. But I liken it to seat belts. Mm-hmm. When I turned 16, I didn't wear a seat belt. Then the law was enacted, in my 20s, and all of a sudden you have to wear a seat belt. I got a ticket for not wearing a seat belt when I was young. Now I don't get in the car without it and wouldn't dream of it because it becomes the normal, accepted standard of care. I think we've got to get these helmets that are specially made and cushioned even on the outside in Pee Wee football, Pop Warner football, bring it up through middle school. By the time those kids are 16 or 17, they're going to think it's the normal thing, and they'll accept it and embrace it. But it's very hard to take a specialized concussion helmet and give it to a 17-year-old kid that's had a concussion. He don't want to be different from his other teammates. So it's got to start young with innovation, education and stuff, and innovation of the equipment.
Do you see any caution and you mentioned Pee Wee football, and of course I've seen them, and you have too, kids out there that look like what they had on their head was bigger than they were,
right,
and they're kind of dawdling around. Is there too young age for folks to consider even thinking about their children? Because there's a big debate about that going on now.
There is, and there's no question that the younger you are when you have a concussion, the longer rest period you need, and the more you are at risk for having future concussions. But I'll tell you, in my practice, I don't see injuries from the Sampson, from the field over here with the community football, with Rec League. I don't see it from the recreation department. I don't see 3rd, 4th, and 5th, and 6th, and 7th graders coming in with injuries very commonly. That's pretty rare. The bigger the kid, the older the kid, the higher the risk. But then that risk goes down at the college level. And I think it's because you've got specialized athletes there with nutritionists, trainers, more coaches, et cetera. But there's a downward, you see fewer devastating injuries in college and even fewer in the pros. The peak is in high school. The peak is in high school, in senior high school. But to answer your question about youth football, I'm not opposed to that at all. I see where tackling has been banned in New Jersey until like a middle school level, and I don't really think that that's necessary because I don't see those types of concussive collisions in the 4th, 5th, and 6th graders playing rec league football.
Well, football for the most part is a United States game. You just don't see. When you say football in some other countries, you're talking kind of kicking variety stuff.
Right, exactly.
But so this is a full impact sport, and I think that's what makes it so uniquely connected to what you do, especially with sports medicine and putting things back together.
The other sports are violent too. A lot of the best athletes now are playing soccer. And those guys are aggressive. They are tackling one another. They are just as aggressive as any football player on the soccer field.
And far less padding.
Right, far less padding. And so there's injuries there, but there's injuries in every sport. And I think that the risks of those injuries, though, is far outweighed by the benefits, because what's our biggest problem in America? So it's childhood obesity.
Exactly.
And so we got to get these kids outside. There wasn't a day, and I know when you were a kid, there wasn't a day that went by that you didn't sweat.
That's exactly.
I see kids every day that I know have not sweated in weeks.
And they're focused on a device in their hand.
Yeah, on some type of a device like that. So I think the benefits of exercise, guys like Dr. Newton doing the Fitness Renaissance, that's a big deal. I think those things are great programs. If Michelle Obama, one thing she's done is brought nutrition and brought some light on childhood obesity. These are all important things. I mean, it's amazing that even in families that don't have a lot of money or extra money, obesity is a big problem. So it's not a socioeconomic thing. It's just purely the availability of high calorie, poor nutritional food and lack of activity.
And that's the education piece I think that needs to be pushed forward,
Right.
not only through our recreation departments, but through offices like
so
you.
those things are important.
Like
So I think it's much better, and I've found in my own kids, the busier they are, the better they do. They do better academically if they are participating in multiple events, whether they're sporting or non-sporting events, but just activities are good for kids, I believe.
And they create better focus.
Yeah, I think so.
So let's talk about it, and we're kind of getting to the end of the show, but I want to try to get some of this into. There's a number of different activities that folks do in this county. Various activities, repetitive, and I'm thinking in the livestock, poultry industry, and so forth. That are repetitive kinds of things. At a point in time, what do you recommend that folks do to try to make last longer? Their structure that they have, their skeletal structure, their muscle structure, if they know that they're doing certain things. Of course, as you mentioned, I've been running now probably, I think it's 78, but after a while, in fact, you mentioned Dr. Newton. Dr. Newton is constantly telling me, look, you need to do other stuff besides just run. So what other stuff does folks need to do, especially that's maybe even thinking about, well, I'll soon be 40 or 50, because as you mentioned, middle age is when you really need to start looking at it.
Well, I'll tell you, you really should include several types of things in your daily routine if you can. It's so hard to get people motivated to do things, but as you get older, I think there needs to be less emphasis on long distance running or on high weight lifting. I think it's better to run shorter distances. If you can find a way to do it with your rear end on a seat and your feet on a pedal, I think that's better. It takes away the impact of it takes away some of the gravity and impact on your joints. I think that in terms of weightlifting, everyone wants to move 300 pounds 8 times. I think it's much better to move 100 pounds 25 times. So it's much better to use lower weight and higher repetition. And then lastly, I'll say stretching is important. And I believe that that's why yoga has become so popular among middle-aged and older people, male and female. But who was it, Jack LaLanne, the old guy?
Absolutely.
That he believed in stretching.
Yeah.
And I think that things are coming full circle back to stretching and not just cardiovascular and muscle training, but getting back to simple old-time stretching, and yoga emphasizes that quite a bit. But you have to maintain the full range of motion of your joints, because when you lose range of motion of your joints, number one, you can't remain as active, but your balance is affected, your stamina, your risk of fall goes up, things like that. In other words, if you can't lift your your foot up onto an 8-inch step, and you only lift it 6 inches, that's why mom falls and breaks her hip.
Absolutely.
So maintain it by stretching every day. I think that's important. You can maintain flexibility, balance, coordination, and help avoid these falls that lead to broken bones as you get older.
And elasticity of the muscle itself then determines the capability of endurance of the joint and all that connective tissue.
Absolutely, it all works together. But I think that 30 minutes of cardiovascular, getting your heart rate up to a target heart rate, 70% of your max. Your family physician can help you determine that number, but just getting your heart rate up for 30 minutes 3 times a week has been shown to be effective at reducing heart disease. So that's walking or jogging or biking or cycling or something like that, swimming. And then incorporating a warm up and a cool down where you're stretching, I think is important.
Well, I think we're probably coming up on the end of the show. It seems like we've gone pretty fast, and I'm thinking we are at the end. My folks are telling me that is the case. So we're 30 seconds out to close. And again, I want to thank you for being here. I want to thank you for coming out. I want to thank you for what you're doing in the community and for stepping up and doing things oftentimes that folks maybe don't know you're doing, but you're there. And as you mentioned, you're sometimes watching the game and learning from it yourself. So thank you for being with us today.
Yeah, sure. Thank you.
Ladies and gentlemen, thank you for being with us. We Should Know. Be back. We look forward to seeing you again next week on the radio. We thank all of our guests, and we particularly say to you today, may God bless.
Thank you for tuning in to this week's episode of We Should Know with host J.W. Simmons. If you have a question, comment, or suggestion regarding this or any episode, please send your emails to weshouldknowedu@gmail.com. And remember to tune in every Tuesday at 2:30 for another informative episode of We Should Know.